Okay, we're ready, I think, for this final part of the Nordic back pain seminar / webinar. It's definitely the most challenging part, I think. So thank you very much, Birgitte, for putting me in charge of moderating that. And I would also like to welcome our 4 distinguished experts who are joining us from Denmark. It's Lise Hestbaeck from the University of Southern Denmark and the Nordic Institute of Chiropractic and Clinical Biomechanics. It is Anema from Free University in Amsterdam in Holland. It's Jaaro Karppinen from Oulu University. I hope I was saying that correctly. And it's Professor Bart from Erasmus Medical Center in Rotterdam. So what will happen is that we have a couple of hours, or however long it takes them, and each of our guests, online guests, have made a short video around 5 minutes where they give a little presentation on their topic, and that raises some issues and questions that we can then discuss in the room. And people who are present over the internet can give comments and ask questions just like they could this morning. And we have not only the expert or the person who's made the presentation, but we also invite the other online presenters to give their perspectives and opinions about these issues. And I've seen the videos, and I think they are really good and they supplement each other very well. So that is the main part of this last part of the seminar. We will then conclude with maybe a more general discussion about moving forward, in particular in the Nordic context. And I think all of you in the room are from the Nordic countries, but many people online are from other parts of the world. We have quite a few from Saudi Arabia, actually. We have people from Asia, South America, the United States, other countries in Europe and Australia. So we have the opportunity to get many perspectives, and I really encourage people who are online from different parts of the world, from different cultures, to contribute, because that's really a voice that we rarely hear in academia. So we have decided to start with the video by Lise Hestbaeck. And Lise will talk a little bit about back pain in children and adolescents and the potential for, if not primary prevention, then prevention of disability. And then we can have a discussion about that afterwards. So let's see Lise's video.
Good afternoon. My name is Lise Hestbaeck. I'm from the University of Southern Denmark and Nordic Institute of Chiropractic. And my task today is to talk about back pain in children and adolescents. And yes, back pain in children does exist. We know the prevalence rates rise deeply from the preteen years to reach adult levels between 18 and 20 years of age. With that in mind, looking at this picture and think about where in the lifespan the potential benefit for prevention is largest. It's pretty obvious to me that the sooner we intervene, the better are the chances of making an impact on public health. But how do we do that? Looking at the etiology, we've for a long time thought about these issues. And there are some associations with physical activity, although they're not as straightforward as we once thought. But the rest of these usual suspects don't seem to have any association with pain. Therefore, we need to reconsider that biomechanical approach and look at a broader picture. We know for certain that there's a large degree of comorbidity with spinal pain, also in children. And this slide only shows one example of a large literature showing the same tendencies. Here we have backache, stomachache, and headache. And you see 26% of the children actually complain of all 3 of them. And if we look at psychological and social factors, we see the same picture. There's a lot of evidence confirming these associations with spinal pain. This one is with stress, where you see a nice stepwise effect with a degree of stress. But we don't know the direction of these associations, but they seem to be bidirectional. So with all that in mind, I think spinal pain should be considered as a public health issue more than a discrete spinal disorder. And therefore, a public health approach should also be part of the solution. Such an approach should not single out individuals at risk, because that might lead the child to an excess and unhealthy focus on pain and cause stigmatism among their peers as well. Instead, initiatives could be targeted to public arenas like, for example, the schools. In these arenas, physical activity should be promoted. Physical education should be strengthened in our schools, and that's not only more of it, but also better physical education. Teachers should be better educated in the musculoskeletal function and how to strengthen it and how to prevent injuries. And also the children themselves should learn about their musculoskeletal system and how to take good care of it. From a clinical perspective, again, a strong element of education is needed. This is particularly important in the young people, where we have a good opportunity to form their understanding of their musculoskeletal system and the strengths and the weaknesses. This is where we can teach them to take the pain seriously, but not be afraid of it. And when the initial symptoms have gone, I think it's essential that we don't discharge the child right away. We see too many repetitive injuries. We all know someone with a weak ankle that never really regained stability after a sprain in youth. There are ways to reduce that subsequent weakness with the right rehabilitation. And last but not least, we have to make all parts of society, especially the health system, aware that musculoskeletal health is an important contributor to all types of health, and therefore we should work together for common solutions. Thank you for your attention.
Thank you, Lise. I think Lise's short video here raises a number of questions that we haven't discussed very much. We talked a little bit about children under your presentation based on data from the Hunt study. But I think the subject of children and adolescents and how to, if we should, and how we should intervene in that age group is very important. And then you also raised the topic of using the arenas where people are most of the day as places where we could meet people and do public health initiatives. For children, it's schools, of course, but for adults, it's more maybe the workplace where people spend most of the wake hours of the day. So many things to discuss, and maybe some of the experts have some opinions on that too. But let's see if some of you have questions or comments for Lise.
Alan Abbott, Linköping University. Thanks for a nice presentation, Lisa. When I look at the current sort of interventions in the school-aged children and the physical education that they receive, there's a focus on children fulfilling the national guidelines for physical activity, and just wondering your perspective with regards to ergonomic, postural type of interventions. How should we maybe educate the adolescents or youth in those areas, apart from physical activity guidelines?
When I say education, I don't want to be so specific about ergonomics, but more how to handle the pain. I like the analogy from Anthony Wolf about comparing low back pain with a common cold, because I don't think we can prevent low back pain, but we can teach the children to handle their low back pain so it doesn't become chronic or doesn't become disabling. So I think the focus should be on an educational program about what the musculoskeletal system can, and that it doesn't hurt to continue with their physical activity, even if they have some pain. That doesn't answer your question about ergonomics, but that's because I don't think we have any evidence in that regard. There's been a lot of focus on, for example, the weight of school bags or how they carry their school bags, but there doesn't seem to be any associations with that. And if we're talking about furniture, I think the best position is the next position. I think the drawback of making really good chairs for the children is that they just sit there. So I don't think that's the way to go. I think we need to get them more active, and they need to get a better understanding of how to deal with their pain, and that pain is a normal part of life.
So I can say to your presenters that we have participants from many parts of the world. So there are more people listening to you than in this room. And you cannot see the room. It's an auditorium. It's full of people. And I assure you, I'm not the only one in the room.
So the experience we had from the Hunt study, from the young Hunt study from 12 to 18 years old adolescents, is that just keeping them doing physical activity at the normal, above the level, or at the medium level, keeps them healthy, and it also has an impact on the well-being, self-esteem, and also mental health. It seems to be associated with a good level of physical activity. And it also seems that the type of sports, like team sports, is very beneficial. So the challenge is that 16-year-olds, from 16-year-old age, it seems to decline a little bit, especially among girls. So I think the school should be more focused on enhancing them to participate actually in physical activity and sports activities.
It's been really difficult to disentangle that relationship between physical activity and back pain. And I think one of the reasons is that it's so closely related to the general well-being and the mental well-being, like you said. Because I think the most, apart from previous back pain, the most valid predictor that we know of is the psychosocial factors, especially the relationship with their peers. So if they have a really well-functioning social life, the risk of pain is a lot less. And team sports does support the social life as well. So I think all these factors are disentangled, or rather entangled. And that's one of the reasons that we should promote physical activity and team sports, because that will improve their mental health as well.
Yeah, we have a comment or question over the internet.
Yes. Hi, Lisa. This is Birgitta.
Hi.
I'm referring to 2 questions from a person on the internet. And this is the questions. Why do most of studies in children focus on strength? And there is maximal strength and not in endurance. Adult studies show no correlation with low back pain and strength, but it shows with endurance. That is the first part. And still regarding biomechanical factors, do you think we can really rule out posture as a correlation? Or still, can it be demonstrated that bad posture in children can provoke low back pain in the future adults?
But the first one about strength and endurance, I'm not sure I agree with that, because there are some studies that focus on endurance as well. and we haven't really been able to establish any links. There's a little thread of evidence with the endurance of the back extensor muscles as predictor for later back pain, but that's very, very low evidence. And otherwise, there's been no association shown. The second one, no, I never rule out anything. The studies that have been done does not show a correlation with posture, but the studies that have been done are not excellent. And there are some ongoing studies. We have one in Denmark where we actually film the children and then we follow them over the years to see if they develop back pain. And there's another one with a strong focus on posture going on in Portugal. So there are better designed studies going on. So ask me again in about 5-10 years.
Hi,
Okay,
it's
we have
Jaaro here. May I comment also?
Yeah, absolutely. Please do.
Yeah, so we did, in our younger birth cohort, we did a sort of cluster randomization using latent class analysis at age of 16. And we took lifestyle factors like obesity, smoking, physical activity, sedentary behavior, and then emotional and behavioral problems evaluated by the youth self-report, which sort of classifies them according to their internalization and externalization. And some years ago, we published already a paper showing that some clusters where there is accumulation of these adverse lifestyle and psychosocial factors, they predict future low back pain. But now we have two papers coming out from my PS student, and it seems that accumulation of this adverse behavior, it sort of predicts more strongly sort of future multi-site pain than low back pain only. And what is the sort of worse? So when these adverse risk factors, psychosocial and lifestyle accumulate, so actually they predict also unemployment. So we have that figures until around age 30, and it's quite sort of interesting phenomenon. So it's not only pain, but also sort of social isolation. I mean, unemployment. So it's a big problem.
Thank you, Jaaro. So yeah, we have one.
Okay,
I think that'll be the final question for this video. We can always pick up the discussion later on because we are getting into other aspects too, which is fine.
Thank you. My name is Kerstin Stigman from Lund University. In Sweden, we had a long-standing trial in Bunkeflothad in the south of Malmö, where children had daily physical activity in school. And the results were really encouraging and promising for health and also for the school results, not really targeting low back pain, but we have these results, and it seems almost impossible to implement these results in school, even though we have a lot of knowledge and also long-term follow-ups. Have you any comment on that? Why is it so hard to change in school?
I wish I had the answer. I don't know. There's a lot of focus on the more academic performance, and it's a long haul to get a broad understanding that children actually learn better if they are happy and well functioning and they have been out for a run in the morning or whatever. And if you look at Japan, where they do exercise every morning with the children, there's a lot to be learned there. But in Denmark, we actually had a school reform 4 years ago based on some results from research showing that physical activity actually increased the children's learning and well-being. And that's been ongoing for 4 years now, and now they're starting to roll it back because I don't know why, but parents and teachers have a tendency to feel that they waste their academic time in school if they do too much physical activity. I don't know what the solution is.
Okay, thank you.
Important perspectives. And
Yes.
I think this is a perfect bridge to the next video, which will be Anema's video, because he will talk about implementation research and the challenges with implementation research and implementation. And he will give some very good examples of studies that he's been involved in. So let's look at Hans' video.
Welcome everyone at the Nordic seminar. My name is Anema. I'm a professor in social medicine at the VU University Medical Center in Amsterdam. I'm also implementation fellow for ZonMW, the Netherlands Organization for Health Research and Development. I will present to you some lessons we learned conducting implementation research alongside clinical studies. You are all familiar with the infamous science-practice gap. Bellis and co-authors calculated that it lasts on average 17 years until evidence-based innovations become usual practice. Although it has never been studied, there are indications that the implementation of ineffective practices in low back pain care lasts even longer. Most researchers have the firm opinion that implementation research should be conducted at the end of the research pipeline, when first efficacy and effectiveness has been established. Curran and colleagues stated that blending clinical effectiveness and implementation designs, the so-called hybrid designs, could speed the translation of research findings into routine practice and lead to more effective implementation strategies. They proposed 3 types of hybrid designs combining clinical effectiveness and implementation research categorized according to their primary research aim. Hybrid 1 studies are testing effects of a clinical intervention on relevant outcomes while observing and gathering information on implementation processes. Hybrid 2 studies have the aim to test both the clinical intervention and implementation strategy on their effectiveness. And finally, Hybrid 3 studies are testing an implementation strategy while observing and gathering information on the clinical outcomes. I will show you our experiences with a Hybrid 2 design study. We conducted recently a study on the cost effectiveness of a multifaceted strategy to implement an evidence-based multidisciplinary guideline for non-specific low back pain in the Netherlands, called the RugActief study. The conceptual model of the guideline implementation was to develop a multifaceted strategy consisting of, on the one hand, a website and social media platforms providing information and video messages targeted to low back pain patients to improve clinical outcomes like back beliefs, functional status and work status, and on the other hand, a multidisciplinary training for professionals like GPs to improve guideline adherence, aiming to reduce referrals to secondary care, diagnostic imaging, and to improve interdisciplinary collaboration in primary care. This should lead to reductions of healthcare and productivity loss costs from a societal perspective. 25 GP practices in 4 regions participated in the study. We used a step-wedge design with randomization at the GP practices cluster level. Primary outcome at the patient level was the back beliefs questionnaire, and guideline adherence was measured with indicators assessed in electronic medical records from GP databases. The results of this study showed that there was no effect on any of the clinical outcomes and no effect on the implementation outcomes, except for a small but significant reduction of referrals to the neurologist. Process evaluation showed that 55% of the patients used the campaign materials, while 58% of the GPs attended the training. The cost-effectiveness analysis showed that the strategy was not cost-effective from a societal perspective, with small, non-significant differences in healthcare and productivity loss costs between intervention and control group. It is difficult to draw firm conclusions from this study because there are some confusing differences in results for implementation and clinical outcomes due to combining clinical and implementation effectiveness in one study. There are some obvious study limitations. To obtain funding, primary research question, power calculation and study setting were based on the clinical outcome and not on the implementation outcome. The specific study setting of academic GP practices with motivated professionals and their patients was chosen to facilitate recruitment and to obtain a high internal validity. However, this specific study setting may have biased the results of implementation effectiveness because there was limited room to improve implementation indicators due to low baseline referral rates to secondary care and diagnostic imaging in the academic setting. What did we learn using the hybrid study design? Most important lesson is to make a clear choice for a primary clinical or implementation outcome in a hybrid design. A clinical outcome if clinical effectiveness has not established yet, and an implementation outcome if clinical effectiveness has been established, for example, when the intervention is an evidence-based guideline. Finally, implementation processes take a long time and are diluted by many barriers in usual practice. For that reason, establishing effectiveness of implementation strategies needs large numbers of non-selected patients due to small effect sizes and needs a long-term follow-up. So, using hybrid designs, look before you leap, but do not wait too long. 17 years is too long. Thank you for your attention.
Thank you very much, Han. There's so much to be learned from these studies, and I'm sure there are people who would like to discuss some of that. I know some of you are involved in implementation studies and the difficulties associated with that.
In my opinion, the biggest problem for implementation studies is that you don't get funding for them. I don't know whether this is also your experiences in other countries.
Lise from University of Southern Denmark. I can start by saying this. Definitely, that is also our experience. But my comment was more to the hybrid design, that I think in particular in diseases or conditions like back pain, it's so important that we study effectiveness on the patient level alongside more maybe traditional process implementation outcomes, since as we've been discussing today, that the specific mechanisms of the interventions are not very clear. So even if we have efficacy trials seen effects, we need to be able to demonstrate if they are also present in real life settings. But it just makes it so complex, and I think it's one of the places where we really need some routine data collections and good use of existing registries to be able to follow large populations of patients and design these studies.
Do you have any comments on?
Yes, I completely agree with you. And most of us are clinical researchers, and we started with clinical research, and that's what we did our whole life. But I think it's very important to add implementation research alongside our clinical studies as well, because we have to be aware what are the barriers and facilitators for future implementation of our results. And when we don't start with that, when we are conducting a clinical study, it will probably be very hard to implement, to make an implementation plan and to implement those results after we have conducted that clinical study.
It seems like such a logical next step, but Bart, you may speak.
Hi. My experience with implementation studies is rather sobering. I think 15 years ago, when implementation research became important, the message was actually do as much as you can, and we called it multifaceted intervention. And maybe one of the two things we try would help. And I think if we look nowadays, I wonder how much we have improved in generalizable knowledge. So I think maybe now in a few situations we have some insight in barriers and maybe also in the solutions, but I wonder if we could already at this moment give, general advices about how to implement an intervention. I think so. My question is, how far have we progressed in this field?
I completely agree with you, Bart, that there is no magic bullet in implementation. So it's depending on the implementation problem. And the implementation problem is a very complex problem. It has many levels. It has also many barriers and facilitators for implementing your research results. And sure, there are systematic reviews on effectiveness of implementation strategies. We've seen this morning that multifaceted strategies in two systematic reviews, that there is no evidence for that. We know that for continued medical education of clinicians, it's very important to do that in a small interactive setting and do frequently audits and give feedback on the behavior of that clinicians. So that's a systematic review, a Cochrane review of IVUS, published in 2012. But that's what we know about implementation strategies for healthcare professionals. But I agree, it's very difficult. You need to target it to the implementation problem and to the barriers that are available for implementation.
Okay, we have a question here from Alan Abbott.
Hi, Hans, Alan, Linköping.
Hello.
You commented on our use of the clinical outcomes, and probably because we're most familiar with those, and we can do sample size calculations based on those. So we choose them as a primary outcome. Just wondering your perspective with regards to how much proportion of change is needed in the clinical behaviors. When we say X-ray, less X-ray referrals, how much is significant, clinically significant change in that? We don't really have any figures to base our problem.
Yes, that's difficult to say, but for implementation researchers, a difference of 5% is already, in 1 year, is already a large change. And it depends also to the baseline values of, for example, referrals to secondary care or imaging. to give an example about the study I presented in the video, we saw a reduction from for GPs from a referral rate of 8% of low back pain patients to the neurologist to 4%. So that's a 4% difference on already a very low referral rate. And that was due to the fact that these were academic GP practices in which there is a sort of academic form of treatment and also adherence to the guidelines. So in usual practice, there will be more referrals to the neurologist with respect to back pain. But a difference of 5% is, for implementation research, is already a large difference.
If I may ask a question, sometimes you have the opportunity to study natural experiments. There may be a change in legislation or something else that just changes the way healthcare is delivered in a society, and you have some before and after measurements, and it's not really a design study, it's not randomized. How do you look upon those studies? I personally think they have given us quite a bit of information, but they're not designed implementation effectiveness studies.
I agree that such natural experiments are very important for implementation research. A journal like Implementation Science likes the randomized controlled designs, also for the implementation strategies. So I think it should be a mixture. And sometimes it's too difficult, what I argued in the video, to conduct a randomized controlled trial because you need large numbers of participants and a long-term follow-up. So in that way, a natural experiment might be a solution, but the robustness of the design is, of course, lower than when we use a randomized controlled design, like a step wedge design, which is very frequently used in implementation studies.
Okay. Nothing over the internet. Okay. Yeah. Wake up. And we have another question here from the room.
Hello, thank you for interesting presentation so far. My name is Maria Sandberg. I'm from Sweden. I have a question concerning implementation research. There is an inherent problem in randomized control studies for implementation research, because then you include or you can randomize people to the active implementation who are not really interested in changing their clinical behaviors. And what we know is that you have a better outcome if people actually want to change their clinical behaviors instead of ought to or are forced to. Then we can know beforehand that we will not have a success. So I would strongly advocate that we also look at longitudinal studies with repeated measurements, and that is very important, and that we look at that we include people that actually want to change their clinical behaviors. There is a sort of ethical dilemma almost in forcing people to change their clinical behaviors. And we know that we don't really succeed very well when we do that. So maybe a quasi-experimental study with a comparison group instead of a true control group. What are your thoughts on that?
I think those designs are also used in implementation research, quasi-experimental and longitudinal designs. In my opinion, we don't force people to change their behavior when we're conducting an implementation a randomized controlled trial. We compare it just to passive dissemination. For example, passive dissemination of a guideline to general practitioners instead of giving them a training
in small interactive groups. But it's up to up to the GP whether they want to change their behavior or not. We try to motivate them, but no, do not force them.
No, force was a wrong choice of word. Actually, I didn't mean that. But
okay.
But feel obliged to, or they are not really actively asking for changing something. Then
yes.
we know that was accepted. That was my point.
Yes, that was exactly also my point. We need non-selected populations of professionals because usually we do the randomized control trials with motivated professionals, and that gives us not a good idea of how hard it is to implement it on people, on professionals that are not motivated or specifically motivated in that area.
Yeah, and we have one last comment here from the room. Question it is from Rachel Buchbinder.
Hi, Han.
Hi,
I've got a question.
Rachel.
We did an implementation trial similar to yours, as you know, and only 2% GP practices wanted to be involved. So how do you change the culture to doctors and other health professionals knowing that it's part of their job to be participating in research?
That's a very good point. It's very hard to involve them in research, and that was also exactly the reason why we tried to find GP practices that want to be involved in this implementation study, but normal GP practices, not academic GP practices, were not so interested to be involved because of the time they needed to invest, and And in the end, we ended in the academic setting, which is, in my opinion, not the ideal setting for implementation research. So I agree completely. And how to motivate those practices who are not interested in implementation, or specifically implementation in low back pain research. I think that's hard, and we have to try to change professionals also from their basic training. That how important low back pain is, because most practitioners are not very interested in low back pain, because it's a difficult matter with respect to treatment and treatment success.
I think I had a more general question. I think that everyone needs to be involved in research. That we don't want to wait 17 years to change practice, and health professionals should think it's part of their job, not just to treat patients, but to keep up with the evidence and participate in research for the common good. So I think it's a basic thing that we keep training people that that's part of their job.
I completely agree with you. It's also one of the CanMed's roles for training healthcare professionals to be also a scientist as a practitioner.
Good. Thank you very much. Thank you, Han, and please stay online so you can continue to contribute. We now go to Jaaro, who is very active in studies on how to implement patient education and the effect of patient education in different settings. So let's watch Jaaro's video.
My name is Jaaro Karppinen, and I'm going to talk about ongoing back pain interventions in Oulu area. Oulu is here in northern Finland, and Linköping is somewhere down there. One of the key messages in Lancet Low Back Pain series was that we need focused implementation of best practice. And we have to reform the education and training of healthcare professionals and change healthcare systems and pathways. And this was the start of our research. We have also translated and validated patient education booklet developed originally by Professor Mark Hancock and Dr. H. Jenkins in Sydney, Australia. About half of the patients agreed that booklet helps them to understand low back pain. And publication about this translation and validation is ongoing now. It's not yet ready to be submitted, but it's coming. And we have used this booklet and evaluated its effectiveness in a cluster randomized control study. And we randomized pairwise primary healthcare centers and occupational healthcare units to either control care without booklet or intervention with booklet used in the area and short 30-minute education for professionals. We have also ongoing benchmark control trial on the effectiveness of classification-based biopsychosocial approach for low back pain in the primary care. And we intend to improve low back pain care pathways in 3 healthcare areas in Finland. Probably we will have more healthcare areas in the future joined with us. We educate the professionals and we use start back screening tool systematically with targeted care, and we use patient education booklet. And the follow-up of the patients is from 3 months to 3 years using web-based questionnaires and medical records. And patient recruitment status about 1 week ago was that we had 252 consents before the approach, and after the approach we have not more than 63 baseline questionnaires, but it's ongoing still, and we are recruiting more patients for the intervention. And some of the premeditated pathways and patient education booklet are used for all patients. This is an example from Mikkeli area, which you see on the map there in southeastern Finland. Many of the patients have nurse contact first, and at the emergency room, in student healthcare, and then there's a nurse to GP where they contact nurse within 0 to 2 days, and they can nurses can go knock on GP's door if needed. Sometimes within the same day, and sometimes a bit slower. And the nurses, they use premeditated phrases, and they use start by screening tool for all patients. And they can refer patients according to risk classification to physiotherapy within 1 week for high-risk patients and within 6 weeks for medium-risk patients. And GPs are needed to exclude red flags if needed. And of course, sometimes patients can be hard to read, and we need GP's contact. And then we have also the usual direct access to physiotherapy and sort of a slower referral to physiotherapy. And we have taught to physiotherapists to use start by screening tool and individually stratified psychosocial care. And then we have, of course, normal GP and occupational physician visits, and we have taught the GPs to use start back screening for all low back patients and refer them to physiotherapy if they are medium or high risk. But this is still needs further training for the GPs. But we are doing that all the time. Education of professionals consists for GPs of 4 45-minute lessons within 1 month and several 1-hour education lessons about start back screening tool, imaging indications and findings, biopsychosocial care for low back pain and sick leaves. And all primary care physiotherapists, they receive 4-day education about biopsychosocial care for low back patients, including demo patients and training. And all nurses receive 1 to 2 hour education of start back screening tool, psychosocial factors in low back pain, and avoiding unhelpful or harmful messages. Finally, but not least, we have in occupational healthcare, individually stratified care for low back pain. It's a cluster randomized control trial, and we have occupational healthcare units across Finland, which we have randomized to active or control units. And we do training of occupational physicians and physiotherapists of the active units in biopsychosocially oriented care, and they have had 4 to 7 days of workshops. And main messages of the training are avoiding unhelpful, harmful messages. Imaging is usually not needed to sort of cut down imaging, and assessment of individual psychosocial factors using StartPath screening tool and a short version of Örebro musculoskeletal pain screening questionnaire. And we use also patient education booklet for the patients. And as the outcomes, we inquire whether the practice of the unit has changed at 1 year. We inquire professionals' attitudes, beliefs, and level of confidence on their skills and satisfaction for treatment opportunities. And we take also patient-based data from questionnaires and medical records, and we did primary outcome calculation based on ODI at 1 year, and we need 600 patients, and we've had now over 200 patients in the active units, but disappointing low number in the control units. And we are continuing recruitment until end of November this year. And I'm sure we will be short of control patients, but cannot do anything about that. And finally, I wish to express my gratitude to my wonderful research team. I couldn't have survived without them. Riikka Holopainen, Anna-Sofia Simula, Maija Paukkunen, and Mikko Lausmaa. Thank you very much, and thank you to all your spectators and my colleagues.
Well, thank you very much, Jaaro, for presenting these interesting projects. I think there's a theme about implementation, but there's also a theme about educating patients and educating healthcare professionals that many struggle with. So I think it would be good to ask some questions and have some debate about patient education or education of clinicians. How do we do it? How do we communicate with people? How general should it be? Should it be very targeted to specific patients? How do we talk to people? In all guidelines that we should do patient education and information. It doesn't say anything about how we should actually do it. Very little, at least.
Was that a question to me?
Well, yeah, well, I was just...
Yeah, so I think for GPs, I guess the most important thing is not to give any sort of harmful messages. Of course, even GPs can be taught sort of validating interview with the patients, but it takes more time, and usually at least in the emergency appointment, they don't have that much time. But for the physiotherapist, we have been doing, and we are continually doing training for cognitive functional therapy and validation and things. So it's we discuss about the things, and we do demos with them. And I think many of the physios we have in these several projects, they have improved a lot. There is of course always some barriers, so it takes time, and they should have enough education, and then there is the problem that if the unit they are working with, if the other workers in the unit, be it GPs or physios or both, if they are speaking different language, so it's more difficult. And of course, it's about the whole system. So we should have that's what I'm doing also on governmental level. So trying to sort of improve the care processes as much as I can. So it's we need from micro to meso level interventions.
Alan has a comment.
Hi, Jaaro. Alan Abbott, Linköping University. Interesting to hear the reception of the handbook that you've been trialing, one based on Mark Hancock's work. Our experience with like a brochure that we provide in the study has been quite positive, and we looked at providing stratified care even for the patient intervention, where the high risk patients, moderate to high risk, and the start back tool are also offered patient education sessions, like a PowerPoint presentation or so. And we've experienced some it's a bit more complex logistical, getting groups of patients together to provide patient education sessions. We're thinking it's maybe why the brochure that we've been using has been used a lot more. Just wondering your perspective on that, providing a handbook, and maybe if there's a need for the patient education sessions, like group sessions and so.
So are you using the same Mark's?
No, not the same book.
Not the same, but a similar one. So in the occupational healthcare unit, we have tried to sort of, and we are doing that constantly. We educate the professionals how to sort of explain the contents of the booklet. And that's a problem. If they are sort of, if the professionals are sort of comfortable with the contents of the booklet, if they can sort of explain that understandably to the patient, so then I think it does its function well, and so we don't have, of course, yet any sort of data on effectiveness of the booklet. I don't know whether it's effective alone. Maybe it should be a part of the sort of bigger process. I mean, and that's what we've been doing in the occupational healthcare units. But anyway, the first sort of impressions from professionals were really positive about the booklet. They found it easy to use, and it's especially with case of imaging guidelines, it sort of helped them to sort of explain to patients that they are not needing any MRI scans at the moment. So it helped them really, and patients' conceptions about the booklet were mostly positive also. Majority of the patients liked the booklet, but of course there were, as there always are, some who don't sort of benefit from the booklet of that kind, but I think the experiences were positive, and I think and key issue here, not with the booklet, but with sort of stratification has been, I think, to sort of take into the team the nurses in primary care, and they are sort of using actively start-back screening tool, and they are sort of making the first sort of decisions where the patient should go and hunt out about the sort of academic centers. So in primary healthcare centers, it's more difficult, yes, but that's what I think is the place where we should go if we want to change the sort of the culture in Finnish healthcare. So it's absolutely primary healthcare centers and occupational healthcare units, and that's what we are doing. Of course, it's also educating medical students. So we've made a sort of national medical student sort of web-based curriculum, and we have Startback also there and speak about these things. So I'm hopeful that we'll achieve to a better solution in the future. I think if you want to hear sort of personal experience, so I think Anna-Sofia Simula is probably online also, and if you want to ask, because she's doing the hard job in Mikkeli area, in couple of other sort of regional areas of Finland, and she's sort of doing the education and sort of recruiting professionals into this sort of implementation study. So if you want to ask sort of her personal feelings about the study, so please.
Okay, thank you. Alice and Han. We take Alice and then Han. Yeah.
Alice Kongsted. We're gaining a little experience in Denmark now with group-based patient education in primary care. And when we first introduced that to clinicians, they were also a little hesitant, like Alan Abbott mentioned, that it could be a difficult logistic to have group-based sessions and maybe to convince patients that patient education is part of effective treatment. But the interviews that we have done so far with patients and clinicians are actually very positive, that clinicians say that the patient education part of an intervention that is both education and exercise is what they feel make a difference to as compared to what they did before. And also patients, they say that they find it very helpful to gain some more knowledge about the back pain. And we haven't done many interviews yet, but the patients we have talked to, they have been in a lot of care before, and they say what was different this time is that now I understand some of my back pain. So I think there are some experience with also group-based patient education in primary care that we are exploring now. But I also think that one of the reasons none of us really wanted to answer when Jan said, how do we do this patient education, is that we have actually very little evidence what should be the mode of delivery. We say that patients should be informed and educated, but we don't do many trials on how should they be informed and educated. What are the best tools for us to support clinicians in the patient education and so on.
Yeah, thank you, Han. Do you have?
Yeah, agreed.
Yes, thank you, Jaaro, for a nice presentation. And I have a question about the study you presented about educating occupational physicians and physiotherapists. With respect to implementation, I think it's very important to involve the employers as well, because workplace interventions have to be shown very effective in return to work for patients with low back pain. Were the employers also involved in that training, or can you tell us something about that?
So in our sort of intervention, we didn't involve the, of course, the employees because we had this over 10 occupational healthcare units, and mostly physios, but at least one GP also, occupational healthcare physicians from every unit, and I know that in Finnish occupational healthcare, so we are now talking about the sort of commitment of supervisors, employees in these processes, and I think that's the way to do it. Not only working modification, but also to get the supervisors to understand about the sort of about the right way to treat their employees, and it's sort of understandable. But for the intervention, for the education, so we couldn't involve the supervisors. Even that would have been very fruitful, I'm sure.
Yeah.
Okay.
Yes, I think so. Because it can be a barrier to involve the employers. For example, in the Netherlands, we needed a system change in which there were financial incentives for employers. They have to pay the full wage replacement for the first 2 years of sick leave. And after that system change, the employers were interested to modify work for workers with low back pain. So I can imagine that when there are no such financial incentives, that employers are a little bit reluctant in changing the workplace.
Yeah, that's true. But then we don't have the workplace in this intervention included, but only the sort of professionals in the occupational healthcare units. And in a couple of months, we will do the interviews. We did the first training in September 2017, and probably in November we'll start to interview, and we'll sort of inquire the facilitators and barriers, for example, to implement the knowledge they received from us to other sort of professionals in the occupational healthcare units. I don't know how far the knowledge has spread in the units, and then also changes on their own practices about harmful messages, about sick leaves, about multi-professional teamwork, and so on. So it's interesting to see, to do a qualitative investigation what has happened, and that helps us to improve the sort of models for the future.
Thank you. We just one last comment, and it's about, I think, a study that I'm a little bit involved in, but that Alan is leading, about how to implement patient education over the internet in general practice where there's so little time. So maybe you can.
Yeah, we were developing material and was interviewing patients, going ask them what they needed, and we conducted 15 interviews, and it was a bit scaring actually to analyze the findings. Most of the patients didn't understand the material; they couldn't read what was written, and I asked them if they could understand other materials received from healthcare. They said it was the same problem. They couldn't really read it, and when they talked to the GP, the most important thing was to know if this was a very dangerous thing, and then they wanted to know what they should do. But what the GP said during the consultation, that can't really remember. And just to mention a few examples, they said this with non-specific pain. A patient said, "Why don't you call it normal pain? You just told me that 80% of patients have this. You just call it normal, because then I'm relaxing and I'm not afraid anymore." And another maybe fun or scaring is that they said this about acute. You think that the patient know what acute pain is. This patient thought it was a very dangerous pain, because acute for this patient was at the emergency department. But we designed a web page. Now we were clever, we thought, and we developed a homepage and invited some of these patients and some new ones to participate in the workshop. And we have heard them before. They said that this is something with us. It's our back. We need advice how to handle our pain. So we have made this, and we call it your back. And then we show it to them, and they look and they say, "Didn't you hear us? We said it was my back. You shouldn't call it your back." I don't know if it, but in the sense of this ownership who's responsible for the pain. So yeah, just some points. I was holding the mic for 5 minutes, so I was kind of behind you. But I think the point of this is that I think we need to test, whenever we have a intervention, information material, we need to test this with the patients. Is this what they want? And with the GPs, because if the doctors don't like it, I'm sure they won't give it to their patients.
Yeah,
thank you.
Good points, and it's known for a long time that patients cannot remember much about GPs sort of messages, and that's why sort of we focus here on physios, and they have about 1 hour time for at least for the first contact, and it's a better sort of environment to get the message well to the patient, and to hear the story of the patient. And Riikka Holopainen, one of my PhD students, she did publish in Musculoskeletal Care early this year a paper about patients' conception, and now it's about physios conceptions, and it's interesting to see how the physios, how they sort of the learning process among them, and we have sort of videoed physios before the psychosocial education, and done that again, and it's amazing, amazing how sort of how the sort of the whole sort of patient investigation by physios changes when they have sort of learned the trick well. Not all of them can do it as well, but anyway, so it's really fascinating and inspiring.
Thank you. So thank you for this fantastic discussion about patient education. It's something we all talk about, and obviously it's a great need to talk more about it and do research in the area. So the last video will be from Bart Koes, and as you may remember in some of the presentations from this morning, the editor of the Lancet took as the take-home message from these very long papers that the greatest need was de-implementation of harmful practices. And they made that kind of the headline and the poster for the whole series. And so far we haven't talked too much about it, and Bart talks a little bit about that in the video. So let's see what he has to say.
Dear colleagues, my name is Bart Koes. I'd like to discuss a topic with you in the field of low back pain. And that is the topic of de-implementation. And the reason for this is that the recent Lancet series on low back pain showed that we do a lot with our patients, and we do too much, and we apply too many interventions, and that is in the field of diagnostics, but also in the field of therapeutic interventions. For example, we do a lot of imaging, MRI scans. We do a lot of surgeries, but also prescribe a lot of pain medication, like the opioids. And we have done that for many years, almost maybe 1 or 2 decades, and we do not seem to have a good idea how to solve this problem. And questions are, should we focus on patients directly? Should we focus on the doctors? Should we focus on governments and health insurance? What are effective de-implementation strategies? Should we focus on clinical guidelines? I do not know the answer, but I think this is a really relevant topic for us to discuss, and hopefully we can solve this in the next decade. So this topic is open for discussion.
Thank you, Bart. Do you have any more comments you would like, or would you like people here to comment?
No, I think this paper is open for discussion, and it nicely follows the discussions about the implementation, I think.
I think one question that is, one issue that's important is who's responsible for the implementation? Is it the clinician? Is it decision makers? Because we are all in a way victims of the system we work in. So how can we work with this at different levels, and what are we responsible for? That's just.
So this is a question for me, or?
You can pick it up maybe while we wait for other people to.
So basically it's a question we have to solve together. And but the question is then, how are we going to succeed? And that is a difficult issue. And in the end, I think it's the people who have the power to change things in healthcare maybe bear the most responsibility. If we leave it open to the current healthcare, to practitioners and patients, then the changes will mostly be very slow and maybe not always in the good direction because of interests, and that also includes financial interests. So I think the shortest way to success is to go to the policymakers, and they can change things. If we, as researchers, have shown that some interventions are not efficacious or even maybe harmful, then policymakers should change maybe legislation, maybe have financial measures taken in order to change things.
Yeah. We have Jon Anker Twap.
Hi, Bart. I totally agree with you. I don't think if we sort of ask the clinicians to act according to what we have as evidence for good practice or good clinical practice, I don't think we're going to achieve anything with that, because we have patients that are interested in alternative treatments, and we have also patients within healthcare that just want to use the opportunities they have, and also the economic incentives to make profit. So I think that one of the things, and one of the, I agree, the shortest way to success is to go to the policymakers and try to convince them that there are harmful treatments out there, and the incentives and everything around it should be taken away. I think that's the only way to do it. And I think also we have sort of in Norway gradually more and more what we call insurance healthcare. So you can buy yourself, an insurance, and then you get a visit by someone, a specialist, and you can have surgery and everything. And if you look at the surgery rates for those that are paid by the insurance companies, they are, or the private hospitals, they are much higher, and they are much more eager to operate than what we do in the public hospitals. So I think we have to work with the government.
Good, and we have another comment or question from here.
Thank you for bringing this interesting topic up. I think we talk a lot about patient compliance to different kind of treatments and therapies, but we don't talk so much about healthcare professionals' compliance to evidence-based guidelines and evidence-based practice. So one suggestion might be that we introduce like a quality assurance system in healthcare when different healthcare units needs to collect statistics on compliance to different guidelines, and maybe this could be a part of accreditation for at least in Sweden to supply tax finance healthcare. might that be a good idea? What do you think?
So, well, first of all, I think guidelines are a good starting point to show what we have regarding evidence and what professions thinks would be good recommendations for the management of patients. I also think that giving practitioners feedback on how they behave compared to colleagues in a region or in a country is also a good thing, like a benchmark or something. I do not think that guidelines are instruments for deciding if in a clinical situation the practitioner and the patient made the right choice, because there can be reasons why they deviate from the guidelines, and therefore they are also called guidelines. They are not the law. So they are. I do not think that we should use the guideline as a checklist on treatment decisions in the clinical practice. So I agree that guidelines are a good starting point for management. I agree that giving feedback to clinicians is a good thing, but but it should not be used as this type of checklists.
Lise, you had a comment?
Yes, because I agree with Bart that we have to look at the legislation and payment patterns, because I think we put too much pressure on the clinicians, because we have to remember that the clinician is always sandwiched between the patient and the regulations. And if we don't change the patient's perceptions, they come in demand of unnecessary treatment. And if the system reimburses unnecessary treatment, it takes quite a spine for the GP to say no. So if we can change the system to reimburse the more high-value treatment, like Nadine was talking about this morning, I think we need to focus very much on public education. We're always talking about patient education, but when the patient comes into the clinic, it's probably episode number 5, 6, 7 of low back pain, and they have a pattern of responding to that pain. So if we can get them before they become patients, I think there's more to gain on a societal level.
Good. One thing that has an initiative that's been somewhat successful in the implementation area, I think, is the Choosing Wisely campaign that's been going on in several countries. And I know, Rochelle, you've been involved in that. Maybe you can comment from that perspective.
Yeah. Before I do, I want to say that I think you need lots of strategies. You can't just have one strategy. And I think Choosing Wisely, the beautiful thing about Choosing Wisely is that it's clinician-led. The clinicians decide what they should stop doing, and it forces them to take responsibility. In Australia, I led the rheumatology one, and I was really surprised. We normally, if we survey our members, we're lucky to get 10% response. But for Choosing Wisely, to choose the top 5 things we should stop doing, I think it was about 65% responded. And so I think that's a start. If we already talk, because our peers are really how we practice. We don't want to do anything too different to what our peers are doing. So I think if you can have those Choosing Wisely lists, it's taken a while for things to change, but there's already evidence from North America that things are changing. They're now doing Choosing Wisely hospital champions, and hospitals are getting on board. And last week I was at the BMJ Healthcare Safety and Quality. Many projects, clinician-led, that have reduced imaging in the emergency department. It's reduced lab tests. It's reduced urinary tests. So I think that's one approach. Can I just say something about de-implementation, that we have to be really careful because the public thinks that de-implementation means that we're taking away something that they used to have. So it's also important to think about what do we replace the de-implemented strategy with. And so that's why I think we have to replace it with effective care. We can't just take things away, and we shouldn't. We should remember the power. I don't know in your countries, but in my country, doctors are really powerful, and politicians don't want to go against them because they have to be elected. So there's lots of things, and you can't just do one thing. You have to have a systematic or systems approach to think about what will work all together. And in terms of public health, our public health campaign actually reduced the number of claims, which means that people that didn't have back pain before saw the campaign and then didn't put in a workers' compensation claim. So that was reduced by 20%. So I totally agree that the public education before they have a problem is really important as well. Sorry, talking too long.
Yeah, we have a question here.
It's actually answered. Bart from Denmark. It's actually answered already. I was thinking about we have to look positively into this. If we're taking away anything, people, clinicians, physicians, people, they'll go against it. But for an example, in Denmark we had the national clinical guidelines, and it's pretty good work. Lots of clinicians and researchers in the groups, and they agree upon national guidelines, but they are not evaluated. I'm pretty sure that if the group developing the national guidelines were the ones responsible evaluating them, they won't be as powerful as if it is the leaders. So we have to collaborate on this, and we have to do the benchmarking you're talking about, Koes. That we have to do the benchmarking in the way that the clinicians, they know what they are doing compared to the group of clinicians, not at the specific patient level, but they can learn a lot about what they're doing according to a group of patients.
We have a comment from Nadine Foster.
I mean, this is a really interesting discussion, isn't it? And I agree that all of these players need to play a role. I'm just very aware that if we place all the responsibility with policymakers to de-implement low-value care, we will simply run into the resistance of clinicians, and we don't want to do that. So we need to take clinicians on the journey, and to do that we need to work with clinicians. So I'm very careful. We must not set up these different stakeholders to work against each other, because that isn't going to help us. I'm just thinking also about the examples of those care pathways. And whilst I realise they're incredibly challenging long-term projects, but I am positively inclined that if you can get all of those stakeholders to agree on a clinical pathway, and you close the back doors in those clinical pathways so that people can't be referred straight to a surgeon from primary care, for example, unless there are very clear indications that they're all agreed as part of the pathway, then I'm positively inclined that these pathways will bring about de-implementation. Of course, it won't be really rapid de-implementation, but as I highlighted earlier, I mean, the early examples we've seen from the UK national back pain pathway, at least is beginning to suggest that we're seeing de-implementation as a result of that. Fewer images, fewer spinal injections, and no fusion surgeries in at least the early adopting sites. So yeah, I guess my just slight concern is that we don't set up these different stakeholders to work against each other. We need to work with each other.
Yeah. Thank you. Yeah, Han.
Yes, I completely agree with Nadine that clinical pathways could be a solution. What is the problem is that it's putting a lot of pressure on the primary care. For example, in the Netherlands, GPs are now reimbursed more by the government because they have an agreement with the government that they should reduce their referrals to secondary care, not only for back pain but for all patients, and that puts a lot of pressure on the GPs as well. So I think that's, and maybe there can be a controversy between the GPs and the medical specialists because of that. So we have to involve all stakeholder groups, and at least the patients are probably the most important. For example, there was a study a long time ago conducted in the Netherlands where patients, low back pain patients, visited their GP, and after that consultation, both patients and GPs were interviewed. And first they asked the GPs about what were the preferences and of the patients, and afterwards the patients were asked what were your preferences. What did you want? Did you want to be referred for imaging, for example? And there were completely different answers from the patient side and the GPs. So a lot of doctors think they know the preference of a patient, but I really think that we need to study more the preferences of patients, what they really want.
Thank you. Wait, Bart, do you have any concluding remarks on this? You said you didn't have any solutions on your video. Do you now?
I like what I heard about, involvement of all stakeholders, including, of course, the clinicians, to solve this problem. And if that works, then it would be perfect. But maybe I'm a bit less positive than Nadine and Rachel. We worked, for example, together with spine of the pain specialist on the radio frequency denervation procedures. And there were questions about the efficacy. And then we worked together with the pain specialists themselves and with the government and with the health insurers, and to decide on a randomized clinical trial evaluating the efficacy and cost effectiveness for patients with chronic low back pain. The trial was designed in full collaboration with everybody and with their consent, and everybody was happy until the end of the study, because it showed that it was not effective what they did and also not cost effective. And then the conclusion was, that it should be taken out of the health insurance, and that was also what the health minister did in the Netherlands, and because that was the whole purpose of the trial. So, but then it got nasty because they did not agree with the results and they were not happy, and so if we would have left it to the clinicians only, then nothing would have changed, and then we will still have this expensive, not effective, and maybe in some cases even harmful intervention. So in some instance, I think you need a little bit more power and a little bit more force, and then only leave it to clinicians.
Very good. Thank you for this discussion. So there was 4 videos, different perspectives on back pain that has been raised in the Lancet papers and many other contexts. Thank you for your input. I hope you will stay online for just a little bit longer, because here in the end, we just have a little bit more of a general discussion and interaction, and there are very many comments over the internet, and many of them don't relate specifically to the topic, but are more general. And Birgitte, we thought maybe you could just read a few of the comments.
Yes, and you are who are present here. You are still invited to do final questions and remarks,
sure.
General ones. We have one person that has introduced an actor that we haven't targeted at all. He says, have you or anyone looked at the difference between information education, the patient, versus informing both the patient and their close family? And this is related to development of chronicity, etc. So it's interesting to, we talk about clinicians, we talk about the system, the decision makers, the patient, but the family. That is, if we say we have a biopsychosocial model, that is quite important. Another question is, when will we see RCTs of back operations versus sham operation? And what do you think the result will be on pain and function in short and long term? Could the results from such a study change the way we look at the back pain and how we treat it? So that was two of them. And if you want to react or comment, you're welcome. John, he really liked the last one, I think.
Thank you. Sham operations, yes. To start with, the same goes for instance, neck pain and operations for neck pain. And we try to design a study where we will do, a cage operation or a fusion. We already done one comparing fusion with a cervical disc, artificial cervical disc, that actually came out in favor of the fusion, the old method, and much cheaper. And the other industry paid studies show the opposite, of course. But then we wanted to do a sham study. And the thing is that it's rather difficult to design a sham study to make an incision on the neck and sort of do the whole procedure without doing the operation and close it again. And we didn't get approval from the ethical committee. I know for the lumbar region, it might be a different story. It's easier to do maybe, and not that complicated. I know that you have done it in Australia, right, Rachel? Oh, we're doing it, yes?
Yeah, please.
It's led by Manuela Ferreira, where we're doing a trial, a placebo-controlled trial of surgery for spinal stenosis. And it's a decompression versus a sham decompression where we're making the same incision and also going down through the muscle layer, but not doing the actual decompression. It's got ethics approval from 3 ethics areas so far, and we're just about to start. The funders are really interested in it, so it is possible. And there's a big network now of surgeons who are really interested in placebo trials for surgery, and I think the more the better, and we'll find many more operations are probably just as good as sham surgery.
And you have the experience with vertebroplasty also.
Yeah, so we've done a trial of vertebroplasty, which showed it was no better than placebo. There are now 5 placebo-controlled trials which have shown very consistent results that the treatment is no better than placebo. But of course, we know there is lots of potential for harm. And there are still, I got a request to look at yet another review that rubbishes the placebo trials, and they know that it works. So there's still a lot of misinformation in the literature. A lot of people believe in the treatment, but the 5 placebo-controlled trials, including 3 with very early, I won't say acute now, early symptoms failed to show a benefit. So can I say one other thing about the families? So I don't know how much work there's been done in back pain, but we know that in gout, family perceptions and history is really important. So we know where there's huge prevalence of gout in Maoris in New Zealand, they just think it's part of normal life and there's no treatment because everyone in the family has gout and there's nothing you can do about it. And until the researchers appreciated that, they weren't getting anywhere with treating people because there's highly effective treatments. So once they understood that the patients have grown up from childhood knowing that all their relatives have gout and there's nothing you can do about it, they didn't get anywhere in terms of treating it. But now they include the families and they educate the families together. They're making a difference.
That's an example of that. Sometimes you should actually introduce treatment. Yeah. Okay, Jon.
I just want to comment on the spinal stenosis because there's a study that was done by a guy in Norway called Greg Lunde. He went to MIT in Boston and compared the surgery rates for lumbar spinal stenosis between Norway and the United States. And the indications were almost the same, but the procedure was totally different. So we did a microsurgery in Norway, and in the United States, they did the fusion. So.
Yeah, sure.
As part of the trial, we've had to get opinions of lots of surgeons who want to be involved. And it's amazing how no two surgeons actually do the same thing. Things that are always done in Victoria are never done in Sydney and vice versa. So even just standardizing as much as possible how the operation's going to be done was, it's amazingly complex. Yeah.
Well, that's a very good reason to say that the trial does not concern you because you do it differently.
Just add that at BritSpine last year in Leeds in the UK, that's the biggest UK meeting of spinal surgeons. We had a workshop on fusion for back pain to discuss whether we should, as a community, try to address the NICE recommendation in the UK that fusion should not only be done in the context of a trial. And I guess it's fair to say that it was amazing to have a workshop at mostly a spinal meeting where we were discussing the idea of a further fusion trial, and that there was mixed opinion amongst the surgeons about whether or not it would be possible to do a sham fusion trial. Some were of the view that a future trial would need to have a sham comparison, and yet others were very, very against the idea of doing a sham fusion trial. So the challenge for all trials is to take with us enough of the community to make a trial possible. And at the moment, my sense of the UK surgeons is this very mixed opinion. I don't know if there are any surgeons in this audience that would want to comment on that.
We have sometimes sham operations when we operate on the wrong level or something happens, and it's sometimes you think that it's very odd that you get a good result just from surgery by itself. But I think that you should, the difficulty is to what do you compare with? If you compare to nothing or if you compare to another type of treatment.
Mm-hmm. I think this is a great discussion. And I don't know whether you can feel the excitement when we're talking about the surgeons, what they're doing. Have you tried to discuss what we do ourselves when we want to do RCT studies, or try to describe what we do to our patients? I like that discussion because we have tried to put up a protocol looking at a RCT study, doing surgery in one arm, looking at spinal stenosis patients. And then we had to decide, what do we want to do non-surgical to the patients? And I tell you, that was a hard way to go. So let's discuss what we do too.
Is there one final comment on this topic, I think?
I just want to say to the surgeons who don't feel that they can do trials to truly find the value of their procedure, I think it's unethical not to know that the treatment's truly efficacious. And for surgeons to think about that, I think is really important. But it applies to all of us, all of our treatments. I don't want to be giving treatments that are ineffective and I don't know about them. So I think we ethically obliged to do the trials, and it's unethical not to.
Good. So you guys who sit at home in your office, how is it to listen to people and not be able to see them? It's just recordings we have because they always say the same things. No. So
I think there is nobody in the room.
No, it's just Birgitta and Margaret and I.
Yeah.
Maybe you can turn the camera that we can see them.
No, it's mounted in the ceiling, so we cannot turn it.
Oh, oh.
Okay. Okay, you will see that there are indeed people here. So we have just a short time left. Yeah. Oh, you. Yeah, that was the idea. Yeah. Okay. 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 Yeah, no one will listen to me now, but that's just like home. So I think it has been a very interesting setup with this interactive part and having people from the outside and being able to discuss the messages from the Lancet papers, which is probably the most high-profile communication about Beck. Okay. Oh. Very good. But I think there's some overriding questions here that we as researchers need to take on board, and Birgitta started a little bit in her introduction, and certainly you picked it up, Rachel, also, and that is the obligation we have as researchers to do better research. And to do research on the very important questions that can indeed move this field forward. We need many types of research, but we need research about, probably most importantly, about effectiveness of interventions and about implementation. And those are some of the things we have discussed today. So how do we become better at working together at solving the really big questions? Because it used to be a couple of 100 years ago, a researcher was just one person who sat in a room all by himself. And then over the years, it has evolved into doing research in teams. And I think that has certainly led to many good things. But now increasingly we realize we need to work together in bigger networks, both to have the academic input into the projects, to get the big funding. The funding usually now these days require big networks like European Union funding, NHMRC funding in Australia, NIH funding in the United States. And to answer the really big questions, we need a lot of money because we need to involve a lot of people in the studies in order to have a very good idea of what we are finding is actually applicable to the real world. And we call this the Nordic back pain seminar. And all of you here, I think, are from the Nordic countries. Some of our guests are from other parts of the world, and we have some people from Holland also here. But we would like to, here towards the end, just spend a few minutes of discussing how we can maybe take advantage of our Nordic community in forming networks here, because we are quite small countries with small populations. We have good researchers, but we don't have a large volume of researchers. And so how can we is the Nordic context a good context for research collaboration? How can we maybe move forward, and how can we take advantage of our societies that are very similar, even though sometimes it can be a little bit difficult to understand the Swedes and the Norwegians. Danes are much easier. How do we take advantage of many of the commonalities that we have here? And we'd just like some perspectives on that. We've been doing some thinking, and we'll have a meeting afterwards to discuss it, but would like some input into this. Also from you, the four experts, if you have any input to that. And that includes Finland, of course, too.
It's not that I have a good answer to your question, but I think it's just so obvious that we try to join forces because we are small countries and we are in a relatively similar context, even with very similar languages and with some registry coverage across countries also, or at least also comparable. So I think there are many reasons why we could do very good and big studies across the Scandinavian countries. What kind of a setup it might be in is, of course, to be worked with, but I think there's a lot of reasons why it would be possible to do very good studies if we join forces. And I think it's really needed because we see that to answer these big questions that are raised today and raised in the Lancet papers and in other places, we need big and expensive studies, so we cannot work in single groups or individual researchers with those questions.
Thank you. I'm Maria Larsson. I'm from the University of Gothenburg and also from the Research and Development Department in primary healthcare in the western region of Sweden. I think the articles in Lancet was a good start. I think this meeting is a good way to that we meet and join. I have about 10 ideas for research, and which I've just put up our ideas this today. What we do need to do, I think, is that you all said that we need to get going. We need to proceed and really get together and do things. And maybe when you meet today afterwards to line up, there's 4 or 5 very interesting things that we need to, the prevention or implementation, and then again meet and really get this to be a very pragmatic study and to join some forces and maybe be just like 4 or 5 in each group. Or, I mean, this is a very big bunch of people. So, and be very concrete. And then maybe invite. There's a lot of you have lists of all of us.
We tend to work more with people in England and the United States and Australia than we do with people in Sweden. I mean, coming from Denmark. And there's just something odd about that in a way, isn't there? Yeah. Was there? Oh, and I think that the new Cochrane review on exercise for back pain is coming out soon. We've been saying that for a long time, but it is coming out soon. And I believe there are around 400 trials. Is that correct? In the review? How much? Okay, but it's increasing all the time. But the main conclusion is it's still very difficult to conclude anything specifically because the trials are too small, interventions are not well described, as you said, Berit, and all of these things that we said when the first one was published in 2005, that's 13 years ago. We just need to do better.
Yeah, well, these networks, network collaboration doesn't have to be only in the Nordic region or Scandinavian region. European is also okay, I think, to include the UK, and that's Great Britain too.
Yeah, well.
Oh, even though you're outside, yes.
Hard border.
No, that's fine. But I think, well, Australia too. Yes, sorry. The one thing I think it's important is that you know, you go for funding for funding such a network. It's important to have a hub or someone coordinating it, and that is funded, and that's an opportunity within, for instance, the COST network in the EU. They finance networking, just you know, maintaining a network that is a good base for applications later. There are other fundings also from the different research councils.
That's how the European back pain guidelines were made back in the day. That's a cost initiative. Yeah.
Right. So it's, you know, looking into those possibilities, I think it's important because Birgitta funded this meeting. So, you know, having sort of basic funding is important, I think, to keep it alive.
We just have like 2 minutes or something left. Or maybe you want to conclude. Yeah.
I don't know if we had any more comments. Yes.
I think it is a great idea to join efforts in coming projects. And I think also we need a hub. We need somebody to coordinate and make this network possible. And then I think the next task should be to, among these very pressing and very big problems that needs to be addressed with research, to meet and see what are the most important research questions to address and what are the research projects that we can join forces around, so we can get some exact and concrete cases to work from.
I can say specifically, and this is inspired by Australia, we're thinking about doing a survey because that you don't have to come together even over the internet, but a survey of Nordic back pain researchers and maybe even MSK researchers about research priorities and collaboration and different things. But I just want to conclude this session. I want to thank Lise and Han and Jaaro and Bart for their excellent videos and interaction. And thank you for your participation.
Well, this is the end of a fantastic day. And I'll move here because the camera has changed. Will this work? You know, I choose this color for certain reasons. You can spot me wherever I am, and it's part of the Swedish colors. So it has been fantastic. It was an experiment to combine the seminar with the webinar and also have you experts interacting via the net and all these technical solutions. But I think it worked well. It was really good. And I have had very good support from Emma and Martin, who were the ones responsible for arranging these parts. We said at the closure that we should comment on how to move forward, and Jan did a sort of summing up of what we have discussed. And I have taken in that we need to change the behavior of the researchers. Changes towards not doing only clinical research, producing evidence, but also be part of implementation and understand those processes and actually do good implementation studies, which we can learn from. And Han, you said no evidence without implementations and no implementation without evidence. So it's an interaction between different research strategies that is very promising. But we need money. And we were lucky to get funding from the Research Council on an implementation project, but it's tough. And together we can try to influence the funding bodies to support us in the research of back pain, of course, and maybe also we need to really work to make them understand the importance of the new direction in implementation science. We say that we have areas of interest, and Per, I think we should go further on to try to summarize our priorities. Partly that has been presented in the Lancet papers, but still for this group and for a continuing networking, this is really a good way also to present to funding bodies what we feel is of importance to solve. I really hope that with you all and maybe other that we want to network with, that we can continue the discussion on Nordic trials. Since we have the registers, we have similar population, and as Alice said also, that we have cultures and healthcare systems that are similar, it will give us maybe power to do larger, better studies with the power to actually give an answer to our questions. So thank you very much. Without you as presenters and the presenters and experts on the screen, this wouldn't have been as good as it turned out to be. You were fantastic, all of you. Thank you very much. And thank you for coming here. And those acting from the web, we have really appreciated all the comments that we have got. This will be useful also for our future planning. So now there is coffee outside where you can continue and wrap this seminar, webinar together from your own perspective. Thank you.